Avascular Necrosis, 8.1. Introduction. Avascular necrosis, AVN, also known as osteonecrosis, ischemic bone necrosis, or aseptic necrosis, is a disease of the bone that results from the interruption of blood supply, causing death of osteocytes and bone marrow elements. Over time, the necrotic bone weakens, collapses, and leads to secondary osteoarthritis in adjacent joints. The hip femoral head is most commonly affected, though other bones like the knee, shoulder, and ankle may also be involved. AVN is considered a debilitating condition as it typically progresses silently in early stages and becomes symptomatic only when significant bone damage has already occurred. Definition. Avascular necrosis is defined as the death of bone tissue due to insufficient blood supply, leading to structural collapse, deformity, and eventual joint dysfunction. World Health Organization, WHO, AVN is ischemic necrosis of bone due to the impairment of blood flow. Clinical definition, a pathological process in which bone cells and marrow elements die due to compromised circulation, resulting in mechanical failure of the bone. Hat for 3, etymology, avascular, a, without vascular, blood vessels. Necrosis, from Greek necrosis, meaning death of tissue. Thus, the term literally means death of bone tissue due to lack of blood vessels, blood supply. 4, epidemiology. Incidence, in the U.S., 10,000, 20,000 new cases are reported annually. Age group, most commonly affects adults aged 30 to 50 years. Gender, males, females, ratio 3:1. Sites affected, hip, femoral head, poise 70 to 80% of cases. Knee, distal femur, proximal tibia, humeral head, shoulder, ankle and small bones, scaphoid talus, lunate. Global burden, higher prevalence in patients with sickle cell disease in Africa, Middle East, and India. 5. Types. AVN can be classified as 1. Traumatic AVN caused by fracture or dislocation interrupting blood supply. 2. Non-traumatic AVN related to systemic diseases, steroid use, or alcohol abuse. 3. Idiopathic AVN, no identifiable cause. 4. Localized AVN limited to one bone or joint. 5. Systemic AVN affects multiple bones, commonly in hematological disorders, e.g. sickle cell anemia. Sham 6. Causes. AVN occurs when blood flow to the bone is compromised. Common causes include trauma, fractures, joint dislocations as hip disc dislocation, medications, prolonged corticosteroid therapy, substance abuse, chronic alcohol consumption, blood disorders, sickle cell anemia, thalassemia, polycythemia, metabolic diseases, Gaucher's disease, lipid storage disorders, infections, HIV, tuberculosis, iatrogenic causes, radiation therapy, chemotherapy, others, decompression sickness, divers, pregnancy-related changes. 7. Risk factors. Prolonged use of corticosteroids, excessive alcohol intake, cigarette smoking impairs circulation, hematological disorders, sickle cell disease, coagulation abnormalities, autoimmune diseases, systemic lupus erythematosus, rheumatoid arthritis, organ transplantation, obesity and hyperlipidemia, prior radiation or chemotherapy. 8. Complications. If untreated, AVN can result in collapse of affected bone joint, secondary osteoarthritis, severe chronic pain, restricted range of motion, limb shortening or deformity, hip AVN, permanent disability and loss of productivity. 9. Pathophysiology. Initial insult. Blood supply to bone is reduced, trauma, clotting, fat embolism, steroid effect, etc. Ischemia. Decreased perfusion leads to hypoxia in bone tissue. Cell death. Osteocytes and marrow elements die within 12 to 48 hours. Bone weakening. Necrotic bone loses mechanical strength. Microfractures. Repeated stress causes trabecular collapse. Joint involvement. Articular cartilage degenerates, leading to osteoarthritis. Signs and symptoms. Early stages, often asymptomatic. Pain, dull, aching, localized pain in affected joint. Hip pain radiates to groin, buttock, or knee. Aggravating factors, weight-bearing movement. Later stages, limping, hip AVN, stiffness, swelling, restricted mobility, functional impairment, difficulty standing, walking, lifting arm. NAC 11, medical diagnoses, history and examination, trauma history, steroid alcohol use. Imaging, X-ray shows sclerosis, subchondral collapse, crescent sign. MRI, most sensitive for early detection, detects marrow changes. CT scan defines bony architecture and collapse. Bone scan shows cold spots or reduced uptake. Lab tests to rule out systemic diseases, lipid profile, coagulation studies, autoimmune screening. 12. Nursing diagnosis. Chronic pain related to bone ischemia, impaired physical mobility due to joint dysfunction. Risk for injury related to bone fragility and collapse. Self-care deficit related to limited joint movement. Anxiety, fear related to disease progression and disability. 13. Medical management, pharmacological, NSAIDs for pain relief, bisphosphonates to slow bone collapse, statins to reduce lipid blockages, anticoagulants for clot-related AVN, surgical, core decompression, relieves pressure, stimulates new vessels, bone grafting, vascularized, non-vascularized, osteotomy, redistributes weight-bearing forces, arthrodesis, fusion of joint in severe cases, total joint replacement, hip knee arthroplasty. 14. Nursing management, pain management, administer analgesics, use hot cold packs, encourage relaxation techniques, mobility support, assist with crutches walker, encourage physiotherapy, education, teach weight-bearing restrictions, medication adherence, complication prevention, monitor for arthritis, fractures, pressure ulcers, immobile patients, psychological support, counseling, reassurance, support groups. 15. Treatment options, conservative, pain control, NSAIDs, physical therapy, limited weight bearing, minimally invasive, core decompression, stem cell therapy, reconstructive, bone grafting, osteotomy, definitive, total joint replacement, hip knee arthroplasty. 16. Psychosocial interventions. 5. 1. Psychological counseling to manage stress, anxiety, and depression. 2. Patient education on lifestyle modification, avoid alcohol, steroids, manage weight. 3. Family support, involvement in care planning and rehabilitation. 4. Support groups, sharing experiences with other AVN patients. 5. Vocational rehabilitation, guidance on work adjustments or alternate employment. 17. Prevention, avoid excessive alcohol and smoking. Use corticosteroids cautiously under medical supervision. Control underlying chronic illnesses, e.g. lupus, sickle cell anemia. Maintain healthy weight and lipid levels. Early screening for AVN in high-risk individuals, MRI in steroid alcohol users. Conclusion. Avascular necrosis is a progressive and disabling condition caused by compromised bone blood supply. Although early stages may be asymptomatic, the disease ultimately leads to severe pain, bone collapse, and arthritis if not treated. Prompt diagnosis, appropriate medical or surgical management, and supportive nursing care are crucial for improving outcomes. Preventive strategies, such as limiting alcohol, avoiding unnecessary steroid use, and controlling risk factors, can reduce incidence and disease burden. With a multidisciplinary approach, patients can achieve better quality of life and maintain functional independence. This version is detailed, medically accurate, and structured for academic or clinical presentation. Thank you. Have a nice day.